Hello and welcome to ACHA's video on management of congenitally corrected transposition of the great arteries, or CCTGA. My name is Carla Deal. I'm ACHA's peer mentor coordinator, and I'm joined today by Dr. Salil Ginde. Dr. Ginde is a board-certified adult congenital cardiologist from the Medical College of Wisconsin, and he's the associate director of the ACHD program there. Thank you, Dr. Ginde, for speaking with us today about CCTGA. And with that, my first question for you is, can you explain what CCTGA is and how it's treated in children?
Well, thank you, Carla. Thank you for the invitation. It's always great to be a part of this great webinar series through the Adult Congenital Heart Association. So CCTGA, it's an acronym that stands for Congenitally Corrected Transposition of the Great Arteries. And some people may know this condition also as L transposition of the great arteries, or LTGA. And it's a rare congenital heart condition where the ventricles or the pumping chambers of the heart are switched and on the opposite side. So to explain it better, it helps to describe the normal circulation and how blood flow moves through what we call a structurally normal heart. So normally there are two sides. There's the right side and the left side of the heart. And each side of the heart has two chambers. The top chambers are called the atria, and they are the chambers that collect blood as it comes back to the heart. And the two bottom chambers are called the ventricles, and they are responsible for pumping blood out of the heart. In a structurally normal heart, blue blood comes back from the body, and it's blue because we've used up the oxygen from our muscles and our organs, and comes back to the right side of the heart. So first to the right atrium, and then through a tricuspid valve, which is one of the doors of the heart, to the right ventricle. And then that right ventricle then pumps that blue or deoxygenated blood to the lungs through the artery called the pulmonary artery. And then that blood goes to the lungs, gets oxygen, and then comes back from the lungs to the left side of the heart, first to the left atrium, and then the left ventricle, and then that red or oxygenated blood goes to the body via the artery called the aorta. So in other words, normally the right side, or specifically the right ventricle, that pumping chamber, is supposed to pump blue blood to the lungs, and the left side of the heart, or the left ventricle, pumps red oxygenated blood to the body. In CCTGA, the ventricle, as I mentioned, or the pumping chambers, are switched such that the right ventricle, which was really designed to pump blood to the lungs, which are lower pressure, is actually switched and on the other side, the left side of the heart, and has to pump oxygenated blood to the higher pressure circulation in the body. And then conversely, the left ventricle, which was designed to pump blood to the higher pressure body, is actually on the right side of the heart and pumps blood to the lungs. And so the reason they call this condition congenitally corrected is that despite the ventricles being on the opposite side, the blood still essentially goes the correct way, and that blue blood still goes to the lungs and to the pulmonary artery, except it's the morphologic left ventricle on the right side of the heart that does the work. And the red oxygenated blood still goes to the body, to the aorta, except it's the morphologic right ventricle that does the work on the left side of the heart. So the reason this becomes important is that the morphology, or the structure and the function between the left and the right ventricles, are very different. So the right ventricle is just not as efficient as a pump compared to the left ventricle. The right ventricle has a poor geometry. It has decreased function or contractility, which is like the squeeze of the heart, and has less coronary blood flow compared to the left ventricle. So normally the pressures in the lungs are much lower than the pressure in the body. So the right ventricle doesn't have to do as much work or work as hard as the left ventricle. But in CCTGA, where the right ventricle has to pump blood to the higher pressure body, the right ventricle, it's really at a disadvantage. So over time, that increased workload can result in the risk for progressive dysfunction of the right ventricle, and that can lead to problems later in life.
Well, thank you for that explanation and kind of continuing on that thought of problems later in life. Dr. Ginde, can you explain if CCTGA is hereditary or not?
The cause for CCTGA is still unknown. We know that we suspect that CCTGA develops early in fetal gestation when the heart is first developing, where the ventricles, which are sort of connected together with the rest of the heart in what we call the heart tube, sort of bends the wrong way. And that kind of forces the ventricles to be on what we would say the opposite side. But at this point, we don't know of the exact genetic cause for why that happens, and we don't know of any environmental association that would cause that change as the heart is developing. The incidence of CCTGA has been relatively steady. It accounts for about 0.5 to 1% of all congenital heart defects, so it's quite rare. And it's estimated that about 5 to 10,000 people in the United States are living with CCTGA.
Thank you. That was very helpful. What are individuals with CCTGA at risk for in the long term after childhood and into adulthood?
Yeah, so with CCTGA, the risk for problems and symptoms is highly variable. So in many cases, CCTGA, it can be an isolated condition with no other abnormalities of the heart. And these individuals typically do really well during childhood, really with no or minimal symptoms, and then develop later problems in adulthood related to dysfunction of that right ventricle over time. But I should mention more often, individuals with CCTGA are born with associated congenital heart defects that cause issues and symptoms early in life, as early as infancy or childhood. So there are three commonly associated structural heart issues that happen in CCTGA. The most common is what we call a ventricular septal defect. So that's when there's a hole between the bottom chambers of the heart, and that can be seen in up to 70 to 80% of individuals with CCTGA. The next most common issue is pulmonary outflow tract obstruction, which refers to narrowing of the blood flow as it's going from that morphologic left ventricle out to the pulmonary artery into the lungs. And that can be present in up to 30 to 50% of patients with CCTGA. And often a VSD and pulmonary outflow tract obstruction can happen at the same time. And the third important issue that can happen is having abnormalities of the tricuspid valve. So the tricuspid valve, as I mentioned, that's the main door that allows blood into the morphologic right ventricle. So there are a variety of abnormalities that can occur with the leaflets or the attachments of the tricuspid valve that can result in progressive leakage or regurgitation of that valve. And that's important because the greater the leakage of the tricuspid valve, that can put more workload on that right ventricle as it tries to keep up with that extra workload or trying to pump blood to the body. And over time, that can result in issues like symptoms of heart failure and abnormal heart rhythms. And then I should mention there's a fourth issue that can happen, and that's related to the conduction system of the heart. The conduction system refers to the electrical signals of the heart, which activate the heart muscles and tells it when to squeeze. In CCTGA, the AV node, which is one of the pacemakers of the heart that tells the top chambers to communicate the signals to the bottom chambers, is abnormal. And that can lead to a higher risk for heart block, either spontaneously or most often occurs during cardiac surgery, where it's more prone to injury when a surgeon is trying to repair a VSD, for example, or open up the pulmonary outflow tract obstruction. And when heart block occurs, that basically means the top and the bottom chambers of the heart can't communicate with each other. And that can, of course, lead to symptoms and need for a permanent pacemaker. But most often, so during childhood, most of the outcomes are focused on just treating these associated lesions like closing a VSD or opening up the pulmonary outflow tract if it's severe enough, or maybe having to place a pacemaker if heart block develops. But in many individuals with CCTGA, they do really well during childhood, even after surgery, and do well even in early adulthood. But long term, the biggest challenge is related to the risk for heart failure. And that's really related to having a right ventricle as what we call the systemic or aortic ventricle that has to pump blood to the body. So, as I mentioned, the structure and the function between the left and the right ventricle is very different. And the right ventricle is just not as efficient as a pump compared to the left ventricle. And so in CCTGA, the right ventricle is in a position where it just has to pump blood to the higher pressure aorta. And over time, that increased workload results in a risk for progressive dysfunction of the right ventricle. And that can lead to symptoms of heart failure and a higher risk for arrhythmias, which are abnormal fast rhythms that can occur from either the atria, the top chambers, or the ventricles themselves.
Well, thank you for that explanation. You said something that I appreciate about the tricuspid valve when you described it as the main door. How do you decide when to repair or replace the tricuspid valve? And does tricuspid valve abnormalities um, increase the risk of heart failure as well?
Yeah, that's a great question, Carla. There's a lot of studies that have looked at the natural history of people born with CCTGA, and a lot of them have basically showed that one of the biggest risk factors for developing right ventricular dysfunction and heart failure is having significant tricuspid valve leakage, or what we call regurgitation. As you mentioned, the tricuspid valve, it's the valve that lets blood into the right ventricle. And if the tricuspid valve is abnormal, meaning it just wasn't formed normally, which is quite common in CCTGA, children with CCTGA can actually have significant leakage even early in life. And that can increase the workload on the right ventricle and lead to earlier symptoms of heart failure. There's been a number of studies that shown that tricuspid valve regurgitation is one of the biggest risk factors for heart failure and can really impact survival long term. So the relationship between tricuspid valve regurgitation and right ventricular dysfunction is really complex. So in many situations, it's not clear which one causes the other. So as I mentioned, in some cases, someone can be born with an abnormal leaky tricuspid valve, and that clearly is probably one of the main causes for why heart failure develops. But in some situations, your tricuspid valve can be fairly normal. It can work really well until later in life in adulthood when RV dysfunction starts to worsen and progress. What happens when the RV is not working well, the right ventricle enlarges or dilates, and that can actually cause more leakage of the tricuspid valve as the leaflets kind of don't touch each other or coapt as well. And so as the tricuspid valve then leaks more, that can cause more stress and workload on the right ventricle. And then that causes more stretch on the right ventricle and more leakage. And so you kind of get this spiral where they're closely linked, where once you start to see a lot of leakage of the tricuspid valve, usually indicates that there's probably some degree of dysfunction already of the right ventricle. Because of this association, there's been a lot of interest in seeing if we can refer somebody with a really leaky tricuspid valve early for surgery to either try to repair or replace the tricuspid valve. The question is, can that, by decreasing the leakage, can that decrease the workload on the right ventricle and prevent or at least slow the decline in RV dysfunction over time and then reduce the risk for heart failure and arrhythmia? And there's actually a few studies that have tried to investigate this. And although it's not definitive, many of these studies agree that if the tricuspid valve surgery is done early enough, when the right ventricular function is normal or only mildly decreased, that can actually improve clinical outcomes. But on the other hand, if the tricuspid valve surgery is done late in the clinical course when RV dysfunction is already moderate or severe and symptoms of heart failure are already significant enough, that it's probably too late and it likely will not help delay the risk and progression of heart failure long term. So in the end, the right answer to if and when someone should undergo tricuspid valve surgery, it really depends. So it depends on the age of the individual, on the RV function at that time when you're discussing intervention, the presence of any heart failure symptoms, and importantly, any other comorbidities that could increase the risk for surgery, like obesity, lung disease, kidney disease. So what we do is sort of take an individualized approach, and as the provider talking to the patient and family, kind of weigh the risks and benefits of doing a procedure on the tricuspid valve and making a decision together.
I really appreciate how you talked about making an individualized approach when making these decisions. And if um, if heart failure does develop, uh, what is um, what is the treatment for that, and how would you address that?
The treatment of heart failure really involves what I would describe as a stepwise approach. So we often start conservatively with medications. So medications can be considered even at a time when we start to notice evidence of RV dysfunction on imaging, like on an echocardiogram or on a cardiac MRI. So even before symptoms start. And then what we do is then add additional medications as the RV function declines or when symptoms of heart failure develop. There are a lot of choices for medications that are being used for heart failure, and most of these medications essentially have been studied extensively in patients with heart failure due to acquired heart disease, like for example, heart failure after a heart attack, when It's really the left ventricle, which is the main pump of the heart. And we hope that these medications work just as well for the right ventricle when the right ventricle is not working as well, like, for example, in the case of CCTGA. But unfortunately, we still don't have strong data to support that. But nevertheless, we do use them often. And so some common medications that we use include medications that we classify as ACE inhibitors or angiotensin receptor blockers. These are medications with names like lisinopril and losartan. And these medications, we call them afterload reducers, where they decrease the workload on the heart by controlling the blood pressure, and they actually may benefit and strengthen the heart muscle itself. We use other medications. We classify them as beta blockers. Examples that we commonly use are metoprolol or carvedilol. They help reduce the heart rate and help reduce the workload on the heart. Other medications that are often used, we call them aldosterone receptor antagonists like spironolactone. We use other diuretics like furosemide to help symptoms of fluid overload. And there are some newer medications that are used for heart failure, like SGLT2 inhibitors or some combined medications called an angiotensin receptor or neprilysin inhibitors. The brand name is called Entresto, and they may have potential to help benefit this population, but it's too early to have data to really definitively show that. But we often do use these medications for medical management. Now, if symptoms of heart failure continue despite medications, we then do consider more aggressive or interventional options. So this includes tricuspid valve repair or replacement, like we talked about earlier. So if there's severe tricuspid valve regurgitation and the RV function is normal or only mildly decreased, we will consider that. But if tricuspid valve surgery is not an option, another intervention that we consider is palliative surgery to place what we call a pulmonary artery band. So that's when the surgeon is able to place a band around the main pulmonary artery, so that's the artery that sends blood to the lungs. And so that restricts essentially blood flow from the left ventricle out to the lungs in the setting of CCTGA. And it's kind of complicated, but basically the rationale behind this procedure is that it helps push the septum or the wall between the ventricle toward the right ventricles. And that reduces the size of the right ventricle and can also help make tricuspid valve regurgitation better. And there are some published theories that show that this can actually improve symptoms and maybe even improve RV function.
So it sounds like there's a lot of options for patients to consider, kind of going back to your individualized approach comments earlier. So, for adults who have had the double switch surgery as children, what complications do you see as people age, and how do you manage those complications?
So because of the concern for the risk for RV dysfunction and heart failure complications late in life in patients with CCTGA, there's a growing interest and experience with this different surgical approach, which we call the anatomic repair for CCTGA, or the double switch operation. So the double switch operation, the goal is to make the left ventricle the main pumping chamber of the heart that pumps blood to the aorta and to the body, rather than the morphologic right ventricle, which is what it is in CCTGA. And remember, the rationale is that the left ventricle, due to better geometry and contractile properties, is a more efficient pump than the right ventricle. And so the hope is by doing a double switch and redirecting the blood that you'll lessen the risk for heart failure long-term into adulthood. How the double switch is performed can be quite complicated, but basically, you can't just switch the ventricles themselves back to the normal side. Instead, you have to switch the blood returning from the atrium to the ventricles, and you also have to switch the connections from the ventricles to the great arteries. So that's why there's two switches, or a double switch. The atrial connections are switched using surgical baffles that redirect the oxygenated and deoxygenated blood to the opposite ventricle, and then the arteries are switched with what we call the arterial switch operation. Since the strategy of the double switch is still relatively new, we don't have a lot of long-term data for how individuals after the double switch operation, how they do into adulthood. We know that since it's such a long operation, most of the risks of the surgery are early in the post-operative period, but once people are recovered from surgery, patients tend to do fairly well in the short and medium-term follow-up. Some of the challenges of the operation is timing. It seems that if you wait too long to do the double switch operation in somebody with CCTGA, that left ventricle can get deconditioned or weak and may not tolerate the strength needed to pump blood to the body after the double switch. And so typically double switch operations are done early in childhood, and rarely, if ever, they're done as a primary surgery in adulthood. While we don't have long-term data on the double switch, we know that patients with other forms of congenital heart disease that have had atrial switches or arterial switches, we know that they can be at risk for certain complications like baffle leaks or baffle narrowing or issues of narrowing of the great arteries. And so those are conditions that we follow closely in people who've had the double switch operation, to make sure that those don't develop long-term into adulthood.
Thank you for that. And as kind of a follow-up to this, what is the risk of a CCTGA patient needing transplant at some point?
As I mentioned, with heart failure, we'll first try a strategy of medications or even surgical or catheter interventions to try to decrease the workload on the right ventricle. But if none of that seems to help, and a patient is to the point of what we call end stage heart failure, where they're in and out of the hospital and need more aggressive therapies, then we'll consider a heart transplant. There are some temporizing solutions before embarking on a heart transplant evaluation, and that includes what we call a mechanical ventricular assist device, or a VAD. So those are mechanical pumps that can help the heart pump blood when it's not functioning properly, and those can often be used as a good way to recover a person with end-stage heart failure so they can get strong enough for a heart transplant. But often when we're considering placing a VAD surgically, then we're often also talking about a heart transplant at the same time.
Thank you. That's helpful. Is there any particular ACHA resources that you would recommend patients with CCTGA explore to help them make informed decisions?
Because of the risk for heart failure, abnormal heart rhythms, heart block, it's really important that all adults with CCTGA follow with a specialist, like an adult congenital cardiologist that understands a lot of the unique features of this rare heart condition. And there's a lot of important information about CCTGA that's continually updated on the ACHA website that can help educate other people and providers and patients about this condition so they can be better informed about the unique features of this condition.
Thank you so much for that. And my final question is, what is one takeaway you would like to leave with our members?
So one takeaway is that CCTGA, it's a very heterogeneous condition. So what I mean by heterogeneous is there's a wide spectrum about how CCTGA can really present during the lifetime. Some have issues early in life. Some can do really well during childhood and don't have issues until much later in life. The diagnosis actually for CCTGA is also variable because if you don't have a lot of associated lesions, the diagnosis can often be picked up later in life, even in adulthood, for the first time, even though it's a congenital heart condition.
Mm.
And so there's really no kind of one way to treat an individual with CCTGA. There's a lot of different options that we as providers have to consider, to help improve outcomes, minimize symptoms, and make sure that people can have a really good quality of life and be able to do what they want to do as they get older.
Well, thank you for explaining that in more depth for us. And thank you so much for your time and for speaking with me about CCTGA. I learned a lot. And I would also like to thank our sponsors, Johnson & Johnson and Abiomed, for their support of this webinar through an unrestricted educational grant. And thank you all for watching. We hope to see you next time. Bye now.
Thank you.